Hello everyone, welcome to my YouTube channel, a dedicated platform for mastering clinical medicine. This channel provides in-depth, structured teaching on history taking, general physical examination, and all the systemic examinations, tailored for medical students, doctors, and healthcare professionals. The focus is on building strong clinical foundations, improving diagnostic skills, and developing a clear practical approach to patient evaluation. Join me as we simplify complex concepts and strengthen clinical excellence through detailed, exam oriented, and practice focused learning. With that said, let's jump to today's topic.
Two are foundations of clinical assessment, which is about general physical examination. This course gives you clear reasoning behind every step. You will learn exactly what to ask, what to observe, and how to document efficiently so you can provide thorough, logical, and professional care from start to finish. So, learning objectives of today's session are that we will get ready for examination, then we learn about significance of general physical examination, and then 11 components of general physical examination, such as general appearance. We look at the general examination of hands, nails examination with findings, fingers, palm examination with findings, and then we look at the vitals, and then general physical appearance of face, nose, eye, mouth, and then we discuss about findings of these components: neck and lymph nodes examination, lower limbs examination, feet examination, and then at the end we check for proximal muscle weakness. Now, how to get ready for general physical examination? Prepare your tools like prepare pen, stethoscope, pen light, tongue depressor, reflex hammer, otoscope for examination of ears, ophthalmoscope for examination of retina of eyes. Sanitize your hands or wash your hands, then maintain patient's privacy, ask others to leave the room, and if your patient is female, then arrange a chaperone. Then approach the patient from right side. Introduce yourself along with telling the patient about your position in the hospital. Explain the procedure and take informed consent. So this is how you get ready for examination. Then what is the significance or importance of general physical examination? It is done for the assessment of overall health so that it narrows our differential diagnosis, like the list of possible diagnoses that we had made, or provisional diagnosis, the most possible diagnosis that we have already made it from the history of patient. And now the abnormalities which are being detected during general physical examination will guide a doctor towards appropriate systemic examination, because we don't perform all the systemic examination on every patient. We select an appropriate systemic examination on the basis of abnormalities that we have found during general physical examination. Now let's discuss about components of general physical examination. The first thing that we have to look at is the general appearance of patient. When patient enters your office, note the style of walking of patient, and then observe the behavior of patient. Either he is anxious, agitated, or aggressive. Education level can be assessed by the choice of words the patient is using, his dressing, and his specific personality that he tries to impose. Then posture and attitude give you idea about illness type. For example, if patient is rubbing the chest bone, it may indicate heartburn. If patient is squeezing the chest, may indicate cardiac pain. If patient is rubbing the buttock and thigh, it could suggest sciatica. If patient is pressing or applying pressure to the lower abdomen, it may indicate lower abdominal pain. And if patient is pressing or tapping on the area around the cheeks or forehead, it particularly near the eyes or nose, it may indicate sinus pain or headache. And if patient is grasping or massaging the lower back, might indicate lower back pain or kidney issues. And if patient is holding or rubbing the throat, may suggest throat pain or difficulty swallowing. Then fifth thing in the general appearance you have to do is to assess degree of illness. It can be mild, moderate or severe, extremely excruciating. Then assess degree of consciousness, like check orientation of patient, ask about time, place or person. Like you can ask him, okay, do you know who I am? Or you can say, where are you right now? Or what time is it? Or what day is it? And if patient has come to you collapsed, or is the patient is kind of in semi-consciousness, then you can calculate the Glasgow Coma Scale. Now, Glasgow Coma Scale is having three components. First is eye component, second verbal response, and third is motor response. In eye component, if the patient opens his eyes spontaneously, it is given a score of 4. If patient opens his eyes only when asked, this is score 3. And if patient opens his eye when pain is given, it is score 2. And if there is no response to pain, then this is score 1. Verbal response, if the patient gives correct answer, like how are you feeling, and he says I'm feeling better now, it is score 5. Or if the patient is confused, like what day is today? It is Tuesday. No, I mean it is Friday, so it is given a score of 4. If the patient gives inappropriate response to your question, like you say how are you doing, and he says get off me, a word, so it is given score 3. And if patient gives incomprehensible phrases or voices, then this is score 2. Like you ask, what is your name, gentleman? He says, right? It is given 2 score. And if patient does not respond at all, this is given 1 score. Then motor response. If the patient obeys command, like you ask the patient to touch his ear and he touches it, it is score 6. If patient cannot obey command but he can localize the pain, for example, you have pinched his forehead and he exactly puts his finger on his head, so this is given score 5. And if patient has withdrawal reflex, like you have pinched his arm and he withdraws his arm, so it is score 4. But if you give pain to the patient and there is flexion of upper extremities and extension of lower limbs, then this is score 3. And if there is extension of both upper and lower limbs in response to pain, so this is score 2. And if there is no response, this is score 1. So lowest score in the Glasgow Coma Scale is 3 and highest is 15. So if the GCS is 13 to 15, it is mild head injury, and if the GCS is 9 to 12, it is moderate head injury, and if the GCS is 3 to 8, it is severe head injury. Seventh component of general appearance is physique. Measure height, weight, and calculate BMI, means body mass index. And if your patient is a child, then plot it on growth chart. Body mass effect, the normal value is 18.5 to 24.5. And if it is above 24.5, patient is considered overweight, and if it is below 18.5, then the patient is considered underweight. Then measure surface area with the help of nomogram. As you see in the nomogram, on the right hand we have scale for patient's weight, and on the left scale we plot patient's height in centimeters. So the middle scale, when you draw a line between two scales, the number it touches on the middle scale is the body surface of the patient in meters square. Then measure sitting height, which is approximately equal to half of the total height or equal to arm span. Arm span is measured from tip of finger of one hand to the next, as you see in the image, the sitting height and as well as the arm span. It is important because we can diagnose some of the syndromes or some of the abnormalities. Like in Marfan syndrome or hypogonadism, arm span is more than the height because lower segment is larger or than the upper segment. In achondroplasia, the sitting height is more than the length of legs. Do you remember Tyrion Lannister in the Game of Thrones, who is portrayed as Hand of Queen? So Tyrion is having achondroplasia. Then, in congenital hypopituitarism, sitting height is equal to length of legs. So, this sitting height and arm scan can help you for diagnosis of some of the illness. Then assess the development of secondary sexual characteristics in children by Tanner's staging scale, as you see in the picture, and it is only done when the patient is fully exposed. And last component of assessment of physic is physical appearance of patient, and it can really point out a diagnosis. For example, in case of acromegaly, patient will have enlarged jaw, nose, and lips. In case of Cushing syndrome, patient will have a moon face and buffalo hump. In case of Down syndrome, there is upward slanting of eyes, which is also called Mongolian eyes, and small ears. And if patient has tall stature and long limbs, it can be indicative of Marfan syndrome. And if patient has facial puffiness and dull expression, it can indicate towards a severe and long-standing hypothyroidism. And if patient has webbed neck, low hairline, and low set ears, it can be suggestive of Turner syndrome. If patient has severe weight loss, goiter, or exophthalmos, it can indicate towards the Graves' disease or long-standing hyperthyroidism. And stooped posture can be indicative of Parkinsonism. The second component of general physical examination is general examination of hand. First, look at the shape of hand. In carpal spasm, which is because of hypocalcemia, also called tetany, the hands will adopt Trazu sign, and then ask the patient to make a fist and look for the knuckle dimple signs. For example, if the fist is normal, so you will see there are four knuckles. But in Down syndrome, third metacarpal bone is short, so you will see knuckle, then there is a dimple and knuckle and knuckle. Then in Turner syndrome, fourth metacarpal bone is short, you will see knuckle and again fifth knuckle and then dimple and then again knuckle. In case of pseudo hypoparathyroidism, you will see that the fourth and fifth metacarpal bone is short, and due to which you will notice knuckle knuckle dimple dimple sign. So this is how you can find these all abnormalities in shape of the hand. Then look at the size, any tremor. In case of fine tremor, you can put a sheet of paper over the hands. See for muscle wasting. Muscle wasting can be seen in case of thenar muscle and hypothenar muscle of the palm. See for palm sweating and grip. Ask the patient to grasp your finger strongly, and state of hydration can be assessed by checking the skin turgor, that is pinch the skin between thumb and finger, and if it subsides slowly, so it means the patient is dehydrated. The other ways of checking state of hydration is look at the eyes. In case of dehydration, eyes are sunken or dryness of tongue, or you will see in the vitals that there is a rapid pulse and low BP, and patient may have postural hypotension. There is decreased urine output and skin elasticity is decreased as we pinch the skin between thumbs and fingers. Then look at the nails. The abnormalities that you can find in the nails is pallor nails, and is caused by anemia, hypopituitarism, and vasoconstriction. Vasoconstriction can occur because of shock like cardiogenic shock, hypovolemic shock, heart failure, exposure to cold, and Raynaud's phenomenon. So this is a homework for you to find it out what is difference between Raynaud's phenomenon and Raynaud's disease. Remember, if a patient is having anemia and the vasodilation is caused, then nails will appear pink. Cyanosis means bluish discoloration. Cyanosis occurs when the concentration of reduced hemoglobin is above 5 gram. Reduced hemoglobin means deoxygenated hemoglobin, a hemoglobin which is having carbon dioxide in it. Now, bluish discoloration also can occur because of self-hemoglobin and methemoglobin. due to toxins and drugs. Now, there is hypoxia at tissue level. Oxygen carrying capability of hemoglobin is lost. So, there will be free oxygens in the blood, and pulse oximeter will show normal oxygen saturation, and but still tissues are having deficiency of oxygen. Cyanosis is of two types: peripheral cyanosis and central cyanosis. Peripheral cyanosis means that there is bluish discoloration of nails, nose, ear lobules, and it can be because of exposure to cold, hypotension, Raynaud's phenomenon, and venous obstruction. On the other hand, central cyanosis means in addition to nails, nose, ears, lobules, there will be blue discoloration of inner surface of lips and tongue. And it can be because of respiratory failure and cyanotic heart disease like Fallot's tetralogy, transposition of great arteries, and Eisenmenger syndrome. Then you can find chylonychia of the nails, that is spoon-shaped nail, and it occurs because of iron deficiency anemia. Then clapping of fingers or nails, that is loss of angle of Lovibond. Angle of Lovibond is between nail plate and skin at the base of nail, and normally it is less than 180 degrees. So angle of Lovibond or clapping can be assessed in four ways: examination of fingers from side, palpate the nail from distal end towards the base, and place a card on nail and nail base, and for this Shamrock's window test. Then you can do grading of clapping. For explaining grading of clapping, I would love to say this, that even when the clapping becomes obvious on inspection, you can still find clapping. How can you do it? By calculating ratio of B over A, and if B over A is greater than 1, it means clapping is present, though you cannot see it with your naked eyes. So B over A, B is the anterior-posterior distance from distal end of the finger to the nail base, and A is anterior-posterior distance from the distal end of finger to distal interphalangeal joint. So if the value is greater than 1 means clapping is present, if less than 1 means clapping is absent. And then you can do grading of clapping. Number 1 is fluctuations. Increase sponginess of soft tissue at the nail base due to increased cell proliferation. Second is loss of angle of Lovibond, which is greater than 180 degree. And I already told you that Lovibond angle is between nail plate and skin at the base of nail. And then there is increased convexity of nail, which is called parrot beaking. And fourth grade is that the distal interphalangeal joint becomes bulbous and it resembles drumstick. And fifth grade is hypertrophic osteoarthropathy, that is swelling and tenderness above the wrist and ankle due to subperiosteal new bone formation. As you can see the grading of clapping in the image. Now causes of clapping. We use mnemonic clapping for causes of clapping. C stands for cyanotic heart disease or cystic fibrosis. L stands for lung cancer and abscess. U stands for ulcerative colitis. B stands for bronchiectasis of lungs. And the other B stands for benign mesothelioma of the lungs. I stands for infective endocarditis or idiopathic pulmonary fibrosis. N stands for neurogenic tumors like schwannoma or neurofibroma, and G stands for gastrointestinal disease like Crohn's disease, celiac disease, or chronic liver failure or chronic liver disease. Then other abnormality that you can see as clapping can have no cause, like it can be a familial, it can run in the families. And there is another called pseudoclapping. It occurs in hyperthyroidism due to maximum resorption of distal phalanx. However, patient does not have the causes of clapping as you see in the mnemonic clapping. Other abnormality that you can see in the finger is a splinter hemorrhage. It is a vertical streak found in manual workers, infective endocarditis due to septic embolia. Now, Splinter hemorrhage is part of modified Dukes criteria for diagnosis of endocarditis. Leukonychia means whitening of the nails. It can appear in normal person or it can be because of chronic liver disease. And why it occurs in chronic liver disease? Because of hypoalbuminemia. Nail pitting is common in psoriasis. Half and half nail, which is also called Lindsay nail, is found in chronic kidney disease, and onychomycosis, that is fungal infection of nails. As you see in the image, splinter hemorrhage, leukonychia, nail pitting, and half and half nails or Lindsay nail, and then onychomycosis, as you see in the picture how it appears. Now we did all the findings, abnormalities of nails. Now it is time that we should discuss about the abnormalities found in the fingers. Let's turn focus towards osseous knot. Osseous knot is a pea-sized painful swelling which is found at the pulp of the distal phalanges and is caused due to deposition of antigen-antibody complexes which are formed during infective endocarditis. In fact, it is one of the criteria of modified Dukes criteria for diagnosis of infective endocarditis. Now, when you know about the osseous knot, then you have to look at the Janeway's lesion in the palm and soles. Janeway's lesions are erythematous rush which is found in patient having infective endocarditis, and these are the vegetations which detaches from the heart and becomes septic emboli and deposited in the palm and soles. Second that we have to talk about is Hiberden knots and Bouchard knots. Both of them are osteophytes which are found in patient having osteoarthritis. Hiberden's knot is osteophytes which are found at the distal interphalangeal joint, while Bouchard's knot is osteophytes which are found at the proximal interphalangeal joint. Arachnodactyly is found in patients having Marfan syndrome. They have thin and long fingers, and they can be identified by Steinberg sign and Walker-Murdoch sign, as you see in the pictures. Then there are some signs of rheumatoid arthritis. Ulnar deviation, where the metacarpophalangeal joints deformity, Botner or buttonhole deformity, where the extensor tendon splits and the head of proximal phalange pokes through. There is swan neck deformity, where there is hyperflexion at the distal interphalangeal joint and extension at the proximal interphalangeal joint. Baker's cyst, rheumatoid nodule, and something which is related due to excessive use of nicotine, that's called tar staining, and is also found in the finger, as just you see in the image. This is a yellow and brown discoloration of fingers, and you can also find tar staining of the teeth, and it is because of nicotine consumption or asphalt base residue on surfaces. So the signs of rheumatoid arthritis are ulnar deviation, but in the feet you can find hallux valgus or hamarto. In the knees you can find Baker's cyst and rheumatoid nodule. There's Botner deformity or buttonhole deformity and swan neck deformity. Since we are done with the fingers, now we jump to the palm of the hand. First, look at the palm for paleness. It can be because of anemia or palmar erythema, which is redness of thenar or hypothenar eminence and found in liver failure, rheumatoid arthritis, or oral contraceptive therapy. Palmar sweating. If palmar sweating is because of anxiety, then palm is cold. If palmar sweating is because of thyrotoxicosis, means severe uncontrolled hyperthyroidism, then along with sweating, the palm is warm. Dupuytren contracture, this is a thickening of palmar fascia, and then there is flexion of ring and little fingers. It is specifically found in cirrhosis. And then there will be skin atrophy because of chronic use of steroid. As you see in the image, there is palmar erythema. As you see, the underlying venules very much prominent. It is because of skin atrophy, and then Dupuytren contracture, where on the palm, on the medial side, you will see a groove made between two palmar fascia. Seventh component of general physical examination is general appearance of face and then abnormal findings of nose, eyes, ears, and mouth. So let's we discuss about the general appearance of face. What does the general appearance of face tells us? Moon-like face is found in Cushing syndrome, mask-like face in Parkinsonism, and if you find periorbital edema, it can be because of acute kidney injury, nephrotic syndrome, nephritic syndrome, angioedema because of anaphylaxis, mixed edema because of hypothyroidism, and right heart failure. Then you can find xanthelasma, which is because of hyperlipidemia, and there is deposition of lipid in the tissues of eyelids. And if you find accumulation or deposition of lipids in tissues other than eyelids, that is called xanthomas. In systemic lupus erythematosus, you will find butterfly rush, and in mitral stenosis, you will find Mallet rush. Both these are present on chicks. Now, how are you gonna be able to differentiate between butterfly rush and Mallet rush? Butterfly rush extends to the dorsum of nose. However, on the other hand, Mallet rush is only confined to chicks and it has not covered the dorsum of nose. Cyanosis because of increased deoxygenated hemoglobin, and due to which there will be bluish discoloration of tip of nose, ear, and lobules. Then check hirsutism in female and hair distribution. For example, in female, pubic hair is limited to pubic area with horizontal upper borders. However, for these, you need to expose the patient. We don't do the full exposure in general physical examination, but you can find some abnormal findings during the systemic examination. In females, the pubic hair is limited to pubic area with horizontal upper borders, and in male, pubic hair spreads towards the umbilicus, means towards the belly button, in a triangular pattern. Now, in cirrhosis, the male pubic hair pattern becomes female type. It means that the upper border becomes horizontal, and there also will be loss of axillary hair. In female virilism, now the word virilism means development of male physical characteristics in female. And it can occur because of excess androgens like testosterone in female, it leading to deepening of voice, hirsutism like growth of beard and mustache, clitoromegaly means clitoris enlarges, and increased muscle mass. And it occurs in polycystic ovarian syndrome, congenital adrenal hyperplasia, and steroid use in female athletes. Male virilism means development of excessive male physical characteristics, like there will be severe acne vulgaris, hypertrichosis means the hair growth will be very much, early baldness, and increased libido and aggressive behavior, which is also being associated with reduced fertility because of increased testosterone level and precocious puberty. Now, we call precocious puberty in boys when the puberty occurs before 9 years, and in females when puberty occurs before 8 years. And the example of male virilism is congenital adrenal hyperplasia, or there is adrenal or testicular tumors. Then check for hyperpigmentation. For example, dark brown pigmentation can occur in Addison's disease. The vulnerable surfaces are those areas which are exposed to friction and pressure. For example, palmar crease or any recent scar, or you can find in the mucosa of oral cavity. Bluish discoloration of buccal mucosa is common in dark colored people such as Negros, or in neurofibromatosis type 1, which is called blue nevus. Grayish-bronze pigmentation occurs in hemochromatosis, and hemochromatosis occurs because of high iron concentration in body. Chloasma or melasma, it occurs during pregnancy or using estrogen-containing pills. Then there is vitiligo. It is an autoimmune disease against the melanocyte. Albinism, where there is deficiency of tyrosine enzyme. Cephalic spot is found in neurofibromatosis type 1. As you see in the picture, it is dark brown pigmentation in Addison's disease and bluish discoloration of buccal mucosa, which is common in Negroes and neurofibromatosis type 1. Then grayish bronze pigmentation in hemochromatosis, albinism. Then coming down, this is melasma and Kef-Ali spot in NF1. And as well as the last one is vitiligo. Then check nose for any deformity, check ears for any deformity with the help of otoscope to see the eardrum as well, the tympanic membrane. Then perform the examination of eyes. In lower conjunctiva, you can find anemia if it is pale, and there can be subconjunctival hemorrhage. The cause of subconjunctival hemorrhage can be trauma or bleeding disorder. While examining lower conjunctiva of eyes, you have to pull down both lower eyelids by your index fingers. Then look at the color of sclera. When concentration of total bilirubin in blood is more than 2 mg, then jaundice is seen, means a yellowish discoloration of sclera and under the surface of tongue. Now question is, why do we see sclera for diagnosis of jaundice? The reason is that sclera is having high concentration of keratin, and keratin has high affinity for bilirubin. That's why it is the first area in the body which gets yellow discoloration. However, there will be yellow discoloration of entire body when there is hyperkeratinemia. But at this time, when there is high level of hyperkeratinemia, means high level of keratin in the blood, the sclera will be white. It does not get yellow discoloration. And hyperkeratinemia occurs due to eating too much carrot, pumpkin, or sweet potatoes, or it may occur in diabetes mellitus and nephrotic syndrome. Then look for bulging of eyeball, which is called exophthalmos and proptosis, and we will discuss about these in details in our eye module. Examine from above, upper eyelid is pulled upward, and if sclera above and below the cornea is visible, then patient is having proptosis or exophthalmos. And if exophthalmos is present bilaterally, it can be because of Graves' disease, and if it is present unilaterally, it can be because of orbital tumor or any inflammation behind the eyeball, which pushes the eyeball forward. Then look for the lid retraction. Ask the patient to look straight, and if the sclera above the cornea is visible, then there is lid retraction. It also occurs in Graves' ophthalmopathy. And lid lag, normally eyeballs and upper eyelids move together, but in thyrotoxicosis, the eyelids remain behind. There are detailed explanation of signs found in Graves' ophthalmopathy. As you see in this image, you can see jaundice in sclera, pale conjunctiva, and subconjunctival hemorrhage. Then we discuss the examination of mouth. First is that you need to know about halitosis, means bad breath. Sickly odor is found in fetor hepaticus, and it occurs because of liver failure. Fruity smell of acetone is found in ketoacidosis. Fishy or ammonia smell is found in the breath of patient having renal failure. And foul odor can be, or bad breath or halitosis can be because of delayed gastric emptying in diabetic patient, gastric outlet obstruction like in adult pyloric stenosis, Zenker's diverticulum, and then tongue coating halitosis, which is 80 to 90% of the cases, and it occurs when the dorsum of tongue is being covered by anaerobic bacteria, and these bacteria produce volatile sulfur compounds. Then halitosis can occur because of tonsillar Krebs infection or tonsillar abscess, and some gum diseases like periodontitis or gingivitis. Then do the examination of lips. The abnormal findings that you can find in lips can be herpes labialis, which is caused by herpes virus and is commonly known as cold sore or fever blister. Angular stomatitis is common in patients having deficiency of iron and vitamin B9. Then you can look for the cyanosis or yellowish discoloration of inner surface of our lower lip. And aphthous ulcer is also called canker sores. The mechanism of aphthous ulcer is totally immunological, and its healing takes almost 4 to 35 days, and it is extremely painful. The cause of aphthous ulcer is trauma, stress, anxiety, and bacteria, and they can stimulate the oral keratinocytes to release pro-inflammatory cytokines like tumor necrotic factor alpha, and these cytokines promote inflammation and leads to destruction of unhealthy cells. Some other causes of aphthous ulcer is lack of sleep, anxiety, as already I discussed, eating too spicy or acidic food, and deficiency of iron, zinc, folate, and vitamin B12. As you see in the picture, it is aphthous ulcer, is angular stomatitis, and herpes labialis. Then look at the tongue of patient to assess the hydration state. And size of the tongue can narrow your diagnosis, like size of the tongue increases in amyloidosis, acromegaly, myxedema, and cretinism. And look at the dorsum of the tongue for pallor and cyanosis. Look for the jaundice under the surface of the tongue, and look at the dorsum of the tongue for atrophic glossitis, which is also called bald tongue, where the papilla disappears and occurs because of deficiency of iron or vitamin B12 and B9. Red tongue can occur because of inflammation or infection like scarlet fever. White patches on the dorsum of the tongue can be because of candidiasis, and you can find some islands of loss of papilla that form a pattern of map. This is called geographical tongue or benign migratory glossitis. It is benign, so it does not need any treatment, and the cause is also not known. It has idiopathic cause. Then you can find black hairy tongue. Most commonly, it is caused by antibiotics like linezolid, doxycycline, erythromycin, metronidazole, amoxicillin, clavulanic acid combination, which comes by the brand name Augmentin, and cefiderocol. You can also find some white patches or plaque on the dorsum of tongue, and it can be indication of pre-malignant condition, and this is called leukoplakia. As you see in the image, I have provided you some illustrative explanation of all conditions and findings that you will be able to find it on the tongue. Then look at the gums. If there is inflammation of margins of gum, this is called gingivitis, and if it becomes so severe, then it is called periodontitis. Hypertrophied gum seen in phenytoin therapy, pregnancy, acute myelomonocytic leukemia. And look for the gum bleeding, which is common in thrombocytopenia, leukemia, and scurvy, where there is deficiency of vitamin C, which is ascorbic acid. Blue line along the edge of the gum is seen in chronic lead poisoning, and if you find inflammation of tooth, which is called odontitis. Then look at the pigmentation of mucosa of oral cavity, like Koplik spot seen in the measles before appearance of rash on mucosa, and is found on mucosa opposite to the second lower molar teeth. And you can find some pigmentation in Peutz-Jeghers syndrome, Addison's disease, and hemochromatosis. Then perform the examination of tonsils. If you find yellow follicular exudates on tonsils, then this is called streptococcal tonsillitis. And if you find the tonsils are covered by white to green membrane, then it is called diphtheria and caused by Corynebacterium diphtheria. In the context of neck examination, perform thyroid examination, jugular venous pressure measurement, and cervical lymph node examination. Like when you want to examine cervical lymph nodes, look for the site, size, number, consistency, mobility with reference to each other. If they are not mobile with reference to each other, this is called matted, and if it has mobility, it is called discrete. And then check its mobility with reference to overlying skin or underlying structures. Check for tenderness, any discharge, or sinus formation. If the cervical lymph nodes are tender, this can be because of acute infection. And if the cervical lymph nodes are matted together, means they are not mobile with reference to each other, then it can be because of tuberculosis. If cervical lymph nodes are discrete but having rubbery consistency, maybe because of Hodgkin lymphoma. And if it has hard consistency with some other primary cancer, then it can be because of metastasis of primary malignancy. So start the cervical lymph node examination by flexing the neck and then palpate the submental lymph node under the chin, then submandibular lymph node under the jaws, and then pre and post auricular lymph node, and then occipital lymph nodes. Then flex the neck laterally and examine lymph nodes of posterior triangle which is present behind the sternocleidomastoid, such as jugulo-digastric lymph nodes, superior cervical chain, deep cervical chain, and posterior cervical chain. And then check the supraclavicular lymph node. Now remember that the left supraclavicular lymph node is called Virchow's node because it receives lymph node from the abdominal organs through left thoracic duct. And if the left supraclavicular lymph node is swollen and palpable, it can be because of metastasis of abdominal malignancy, and this is called Toisia sign. Then perform the examination of lymph nodes of anterior triangle of neck which is present in front of the sternocleidomastoid. After examination of cervical lymph node, examine axillary lymph node and palpate skin around the neck for any crackling sensation, which can be because of subcutaneous emphysema. And subcutaneous emphysema can be caused by any penetrating chest injury, or during thoracic paracentesis, or during chest intubation due to pneumothorax or rupture of esophagus, or there is any active cellulitis which has developed to gas gangrene. Then go towards the limbs. Palpate the epitrochlear lymph nodes, which is found on the medial aspect of elbow 4 to 5 cm above the epitrochlea. And then palpate inguinal lymph nodes. And if you find that the inguinal lymph nodes are enlarged, then it is because of disease and it is drainage areas. I think it's very important for any doctor or medical student to know how to locate the inguinal lymph nodes. For locating inguinal lymph nodes, you should have knowledge of these two phrases. One is midpoint of inguinal ligament and other is mid-inguinal point. Midpoint of inguinal ligament is the halfway between anterior superior iliac spine and pubic tubercle. On the other hand, mid-inguinal point is halfway between anterior superior iliac spine and pubic symphysis. So mid-inguinal point is a key reference for identifying inguinal lymph nodes. Then check for edema, and edema is of two types, non-pitting edema and pitting edema. Non-pitting edema is that when the edematous area is being pressed, the mark of the pressing finger cannot be imprinted there, and it can be caused by angioedema, mixed edema, or lymphatic obstruction, by filariasis caused by roundworm, and this roundworm is called Wucheria bonecrafti, or Malroy syndrome, or any surgical removal of the lymph nodes or irradiation of the lymph nodes can lead to non-pitting edema. Then pitting edema means the mark of the pressing finger can be imprinted. You can find pedal edema because of right heart failure or constructive pericarditis or pericardial effusion, or it can also be found in the inferior vena cava obstruction. Periorbital edema is also pitting edema. It can be caused due to renal failure, nephrotic or nephritic syndrome. Or you can find generalized edema because of cirrhosis, malnutrition, and malabsorption. And generalized edema is caused because of hypoproteinemia. And severe generalized edema is called anosarca. And then some localized edema, which is confined to a specific anatomical region. For example, it can be occur because of venous obstruction, bedridden, or has been immobile for a long time, or infection or inflammation like cellulitis. Then perform examination of it for clapping, chylonychia, cyanosis, and signs of peripheral vascular disease, and their cause are the same. So at the end of your general physical examination, ask the patient to stand up or sit down or walk and check the proximal muscle weakness. Thank you for being with me till the end of this session. Please subscribe, follow, and share. And this course, that is Foundations of Clinical Assessment, is having 6 parts. Make sure you watch all of them. They will be very helpful during your clinical practice.